How about the positive diagnosis? First, we begin by the anamnesis. We asked the patient about his smoking habits, if he had occupational exposures. Then we ask him about the onset of the respiratory signs and their evolution, and if he has some extra-respiratory signs. Then we pass to the physical examination. We evaluate the general condition by the performance score or the Karnofsky scores. Then we will look for the paraneoplastic syndromes like the nail cabin and the gynecomastia, who are very often seen if we have a lung cancer. Then we pass to the pleuropulmonary examination, looking for condensation syndrome, pleural effusion syndrome, superior vena cava syndrome, Claude Bernard-Horner syndrome, or an exquisite pain on palpation. As you can see here, we have superior vena cava syndrome with edema, cyanosis, and some dilatation of the collateral vena at the upper part of the thorax. Here we have the Claude Bernard syndrome with ptosis. We could not see really good the mucus and the ophthalmia. Then we have to examine the other organs, looking for secondary localizations like peripheral lymphadenopathy, hepatomegaly, bones, pain, etc. After the physical examination, we have to do systematically chest X-ray if we suspect a lung cancer, and you have to know that it may be normal in 5% of cases. And how it is possible? Because sometimes we have some proximal tumor, small tumors into the bronchi, and they will not be seen on the chest X-ray. So if we have some risk factors with a clinical suspicion of the tumor, like cancer, we have to refer the patients to a specialist for a bronchial fibroscopy and CT scan, even if the chest X-ray is normal. Some presentation of the tumor on the chest X-ray, we could have a proximal tumor, which is near the hilum with blurred external limits, and we are talking about crab's leg, like the legs of a crab, with sometimes the internal limits will be confused with the mediastinum. It is not the case in that chest X-ray. We could have an atelectasis of all the lung or a part or a lobe of the lung, and it is a systemized opacity which is dense, homogeneous, with a triangular aspect with retraction. Here we could see that the minor fissure is retracted, and also here we have the trachea which is retracted, and as we have said, it could be segmental, lower, or the whole lung will have an atelectasis. Sometimes it could present like a small rounded opacity which is peripheral, sometimes with good limits. Sometimes the limits will be irregular. The tumor can present like a pseudo-abscess, but with a thick wall. The wall is thick if we compare it to the abscess due to an infection, and with irregular internal limits. We have what we call the Ponkostentobias syndrome. Is the case of the patient who had a tumor at the apex of the lungs, and we have often a costalysis of the posterior arc of the first two ribs, and clinically they will have syndrome of Claude Bernard-Horner. Some misleading aspects. For example, if we have that it's an alveolar opacity and we'll suspect pneumonia. But if we have a recurrent pneumonia on the same place, or pneumonia with not good clearance, who did not disappear up after treatment, we have to suspect lung cancer and to do a bronchoscopy. And sometimes we have a small peripheral nodule. If we have risk factors and clinical context, we have to suspect also lung cancer. Here we have a peripheral nodule that we are allowed to see it better on CT scan. And here we have a proximal tumor near the hilum, and we are seeing it better on CT scan. Some associated signs, we could have a pleural effusion, we could have a parietal mass, and we could have a mediastinal widening with the tumor. So, what are the rules that we have to keep in mind? Any thoracic or extrathoracic symptoms in a smoker should suggest the possibility of bronchial cancer, so we have to complete clinical examination and do a chest X-ray. Second, any hemoptysis should lead to a search for bronchial cancer in smokers and non-smokers. And third, if we have risk factors with clinical suspicion, even if we have a normal chest X-ray, we have to refer the patient to a specialist for bronchial fibroscopy and CT scan. What about the chest CT? It's the key examination. We have to do it with the injection of contrast product, and its interest is it allows us to have the positive diagnosis while seeing lesions that suggest a cancer. It's guide the diagnosis methods. If we have a proximal tumor, we will do fibroscopy. If it is peripheral, we are going to do a transparietal biopsy. And it assesses the local, regional, and the distance extension if we have some metastasis at distance. As you can see here, we have a tumor with limits that are not regular, they are speculated. We have a pleural effusion and some lesions on the other part, on the other leg. Here we have a proximal tumor with the extension to the mediastinum. Here we have a peripheral tumor with the extension to the bones, the ribs. Here we have a peripheral nodule with regular limits. And this is a pseudo-abscess tumor, and we are suspecting tumor because of the thickness of the wall. So we have the diagnosis, but we have to know what is the anatomopathology of that tumor, because the treatment depends on the anatomopathology. So how we can have that simple? First, the bronchoscopy, it is systematic and usually allows the histological diagnosis. It allows us to visualize the proximal tumor who are near the hilum in form of endobronchial bud or mass. It could be obstructing or not the bronchial lumen, or like just in infiltration of the bronchial wall. Sometimes you have just an extrinsic compression aspect, or a bleeding, or even a purulent secretions. So we do the biopsy, and if we have a peripheral tumor, the bronchoscopy is often normal. We can't see that tumor through the bronchoscopy. So as you can see here, we have a mass, a endobronchial mass that obstructs totally the lumen and the bronchial lumen. Here we have the infiltration of the wall with obstruction of that lumen. And here we have the aspect of compression extrinsic of the lumen. The diameter of that lumen is bigger than this one. Then we have what we call the transthoracic biopsy. If we have a peripheral nodule, we have to do the transthoracic biopsy. Thanks to the ultrasound or CT scans, it allows us to have biopsies and with rare complications like pneumothorax or hemoptysis. As you can see here, we have a transthoracic biopsy thanks to the scan. And here we have the ultrasound, and we can see the tumor here. And thanks to that, we call that the true cut. We could go here and have sample of that tumor. What are the other ways to have a biopsy? If we have a peripheral element like adenopathy, we could do a biopsy of that adenopathy or that subcutaneous nodule. If you have a pleural effusion, we could do pleural biopsy. If you have some adenopathies on the mediastinum, we could do what we call mediastinoscopy, like we see here. We go to the adenopathies on the mediastinum. Sometimes we have some masses which are near the trachea or the bronchi. We are doing what we call the bronchial echoendoscopy. It's like the bronchoscopy, but we have in that part a small echography that allows us to see the tumor, and with a small needle we go to that tumor and we take some samples. Sometimes we go through the esophagus, and we are talking about the esophageal echoendoscopy.